So, just got some acknowledgement. So, Justine Powell's a nurse unit manager at RFDS and provided me with some information and photos for their loading systems. And Tony Hucker's a QAS paramedic educator, also provided me with some information on the bariatric ambulance service that QAS provides. So managing the morbidly obese in ED. So some of the issues I wanted to cover were access to ED, look at some of the logistical issues within your emergency department, and also some of the medical issues. So on a local perspective, 2007 study, there was at the Austin Hospital in Melbourne, 23.7% of patients attending were obese, about 4.1% morbidly obese. So translated that into the sort of local environment, sort of Logan, for example, with 60,000 adults a year, that'd be 40 plus obese patients a day and 7 morbidly obese patients a day. It probably understates it because we're in southeast Queensland, we've got a high island, a high Maori population, and certainly the island countries are some of the highest rates of obesity in the world. So getting to ED, I mean, firstly, sometimes the issue is getting out of the house. So there's been some highly publicised cases. On the left side, that was a 300 plus kilo gentleman who had to be winched out of a window. He was living in a sort of like a tower attached to the bridge at Indooroopilly. That was a couple of years ago. The photo on the right's a youngish girl, I think she's about 19, who they really literally had to remove the wall of the house. This is in the UK, to be able to safely get her out of the house and get her to hospital. So obviously that requires a lot of resources and takes a lot of time to get the sick patient out of there and into your hospital. So the QAS standard response vehicle. So the Sprinter ambulance is a single stretcher ambulance. In the rural areas, you might come across the Land Cruiser. The Striker stretcher is the standard stretcher, so can take up to 228 kilos, but it's pretty narrow. It's 55 centimetres wide. So even if you've got some of the heavier patient, it can be quite unstable when they're sort of hanging over the sides of it. So the other issue is it's got to be manually lifted. So if you've got it sort of lower or it's on the ground and then lifted up, the paramedics actually physically have to lift it up. So it's sort of a high risk for work injuries. So with that routine transport ambulance, the distance between the stretcher and the wall of the ambulance is fairly small as well. So if you've got a patient, a bigger patient or a short or wider sort of patient on the stretcher, they can be quite unbalanced and sort of leaning over into the centre, and it's sort of a risk again when you're loading and unloading the ambulance. So QAS has invested fairly heavily in recent years in they've got specialised transport and retrieval units, so as well as transporting paediatrics and neonates, it also transports bariatric patients. So it's a different type of ambulance. It's a bigger ambulance, and it's also got some specialised bariatric equipment. So this stretcher is much wider, so it's 750 mils wide, so half as much again as your standard stretcher. It can take up to 500 kilos. Probably most importantly, it's powered, so it raises and lowers with battery power, so it's sort of much safer for staff. Also getting in and out of the ambulance too is a powered process, so you're not sort of physically pushing the patient and stretcher into the ambulance. So the configuration of the Stru ambulance is different as well. So the patients, because it's wider in the back, the stretcher is placed in the middle of the ambulance, so you've got access on both sides, and it makes it a lot easier for the staff trying to manage the patient in the back of the ambulance, as well as the patient's not sort of being pushed away to into the centre aisle from the side of the ambulance. So there's other specialised equipment too as part of the service. So this is a hover mattress, so it does what you'd expect to do. So it's plugs into 240 volt power and goes under the patient, and you can move it across quite easily to move your patient from bed to stretcher or vice versa. So this is another lifting device where you can sequentially raise the patient on these mattresses. And you can get the patient either in a supine position, or you can get them into a sitting position. So if you've got a patient who's on the ground, you can use a device like this to try and lift the patient up, so you can either get them in a chair or onto a stretcher. So currently the bariatric unit locations, there's one in Metro North, one in Metro South. So there's one in sort of Toowoomba and one in Townsville. So it leaves large parts of the state uncovered, unfortunately. So if that's the requirement to move the patient, there could be significant delays in trying to get access to that ambulance, or we're going to have to look at alternatives. So in rural and regional Queensland, we're often faced with having to retrieve patients from over long distances. Retrieval services transports about 20,000 patients a year, so that looks after sort of primary response, but predominantly it's sort of inter-hospital transfers. There's 11 helicopter bases and 7 fixed-wing bases. So it's very important to make sure we get the right aircraft to the right patient, that we have some idea about the size of the patient and where they'll actually physically fit in the aircraft. So this is the chart we use and ask hospitals to complete. So the big issue, as well as the weight, obviously, is the width of the patient, so where they can actually fit through if it's a standard door aircraft. So this is just the RFDS standard sort of setup, so the King Air. So it's a life support system. So the stretcher width is 48 centimetres, that's narrower than the QAS stretcher. And the door width of the aircraft is 60 centimetres, so it's a pretty tight fit. So the system can look after 180 kilos. So with your attached equipment, which might be ventilators, monitors, syringe drivers, that can weigh up to about 22 kilos. So effectively using that system, you could carry a patient about 157 kilos. So how it sort of works, so there's a deck that clips onto the top of a trolley, and the patient will be on top of here, and that attaches to sort of like a ramp that goes up to the loading system in the aircraft. So to get the patient up to the aircraft, you physically have to push the patient up here and up the ramp. So that's a manual process, and then the patient sort of locks into place on this ramp here. So when the patient's locked in, you can activate there's a hydraulic lifting system which pushes this ramp up to a horizontal position. You can then have to physically push the patient onto the life support base in the RFDS aircraft. So it is a risk for staff again with the manual handling that's required. So over the last few years, RFDS has invested in some wide door aircraft. So these aircraft have a cargo door, so it's much wider, and it's a different loading system. So it can potentially carry a patient up to 247 kilos, but with equipment that would be, the patient weight would be maximum sort of 222 kilos. So this is the sort of loading system. There's like a frame that supports the stretcher, it's a powered system, and then you can manoeuvre the patient into the aircraft and onto the bed. So there still are issues because of the size of the cabin in the aircraft, or where the stretcher has to be in the aircraft. So potentially patients still may not be suitable if they're too wide for the stretcher and leaning too far into the centre of the aircraft. So what happens if the patient weighs over 247 kilos? So this has happened, and there are cases where you have to move patients of this size from rural and remote areas. So the road options, they're resource intensive, so you have to fly a team out generally to the patient so you can at least provide critical care to the patient. And you can also drive your bariatric ambulance out to the patient, but some of the distances involved, like Longreach to Rockhampton one way, 7.5 hours. Quilpie to Brisbane, for example, is 12 hours. So it's a significant logistical exercise, and physiologically it's very demanding on patient and staff as well. And there's sort of fatigue considerations, and you might have to organise different crews and medical teams to change over. So clearly, while you can provide the critical care to the patient, if the patient's got a time-critical surgical type emergency, they obviously not going to receive that care on the way in. So the other options, the Australian Defence Force options, which I think was last used probably about 6 or 7 years ago. So to use a C-130 Hercules, it needs a few days' notice to organise and configure the aircraft, and the ambulance can actually be carried in the aircraft. So it's a very expensive option. So when it was last used, the example was a 200 plus kilo patient who was at a sort of regional hospital and was being retrieved to a tertiary centre. So the patient had respiratory failure and pneumonia, was being managed at the regional hospital with NIV with high oxygen requirements. So the C-130 military ambulance was used. The patient was moved into the ambulance, secured to a mattress on the floor of the ambulance. The patient was then intubated in the ambulance for transfer, and then the ambulance was driven onto the aircraft. So in flight, the patient was managed in the back of the ambulance in the aircraft, and then driven off and transferred to hospital at the other end. So it took 3 days to organise, and the cost was about $400,000. So looking at some of the ED specific issues, so what do we know about how we manage morbidly obese patients in ED? So the research is patchy. Mostly it's from the US. There is some local research, but it's a few years old now. So we know that the length of stay in ED for these patients is longer. We use CT more often with these patients, probably about 10%. From low 40s to low 50% of patients needing CT. These patients are more likely to get IVs and blood tests done. They've increased rates of intubation, high admission rates. And 50% of these patients are more likely to suffer from an injury requiring medical attention, so we see more injury-related stuff. So the logistical issues within ED, so ideally some forewarning of arrival, so we can get the equipment immediately available and staff to be able to sort of help offload the patient. And ideally if you can directly unload the patient onto a heavy-duty bed or a wheelchair. So not all our patients need him in a bed, some of them are ambulatory and quite would be fine in a wheelchair. So a standard hospital bed takes up to about 200 kilos, and the heavy-duty beds can take up to sort of 500 kilos. So you need a lifting device or hover mattress to assist with transferring the patient. So that's one of our wide-body wheelchairs. And so where to manage the patient in ED? So probably most patients would be managed in a standard cubicle or resus room, and the trolleys are rated to 200 kilos plus. For some patients, particularly morbidly obese patients, they're better managed in an appropriately equipped bariatric room. The staff need to be trained into the use of the equipment. So this is a room set up in the ED ward at Logan Hospital. So it also doubles as an isolation room as well. So we've got the bariatric bed here. We've got a lifting device here, so you can transfer the patients on and off the bed using this device. And they can also be transferred across to the toilet, and there's a separate bathroom there. So, and I guess having a single room for these sort of morbidly obese patients does allow them to some degree of dignity as well. So that's our bariatric toilet, which is absolutely huge, as you can see. So some of the medical issues when we're managing these patients in ED, airway ventilation is obviously a big one. I think we've had significant improvements over the last few years around our understanding, pre-oxygenation, positioning of patients with intubation, and the work of there's an American emergency physician, Scott Weingart. So a lot of the work he's done over the last few years really changed the way we practice. So using strategies like apneic oxygenation, delayed sequence intubation. We have better ventilators we can rely on, more availability of video laryngoscopes, and we're using non-invasive ventilation more, but nothing replaces the expertise and the experience in the team. And with these critically ill patients, we have a team approach with our anaesthetic and ICU colleagues as to get the best outcomes. So vascular access is obviously something also makes us sweat quite a lot. I think again our over the last few years we're using ultrasound much more widely and we're much better at using it, so which helps significantly. But you've got to be able to access longer cannula. So most cannula now are probably about an inch and a quarter. So we do have to access to longer cannulas. And in sort of time critical situations, we need to do something like the EasyO intraosseous device. So when it came out, probably about 10 years ago, there were sort of two size needles, one, the pink one, which was under 40 kilos, the blue one over 40 kilos, and they've reintroduced one that's double the size now, the yellow one for the larger patients. But this will get us access very quickly in those sort of time critical situations, and you can use it. You can give any sort of fluid you want or medications through the intraosseous. So diagnostic uncertainty. So we have trouble with our examining patients, and problems with plain imaging. And I guess a lot of that we're using CT more frequently. So CT at Logan has a 250 kilo limit, so which is helpful. Diagnostic uncertainty makes it hard to refer patients, so which adds to sort of increased length of stay in ED. So pharmacology is an issue we have to be aware of. So depending on the medication. Whether you use total body weight or ideal body weight to work out your dosages. Paediatric patients too is an issue you have to consider. So I think in the paediatric ward at Logan they do have bariatric rooms set up for bigger patients. So obviously they're taking up to 15-year-olds, so you can see some pretty big patients. But talking to our paediatric director, they see 80 kilo 10-year-olds and 35 kilo 4-year-olds. So working out your medication dosing, we can use a Prosilo tape which will measure the height, and that'll determine the ideal body weight of the patient. We know with kids they get worse outcomes in burns, asthma, with injuries, and we also have to deal with the incidental findings such as hypertension and diabetes in these patients when they come in. So the issues that have been identified by ED staff, so medical staff, their main issues around physical examination, anatomical landmarks, procedures. Nursing staff, it's positioning the patient, assistance with clothes on and off, mobilisation and IV cannulation. And for radiographers, it's positioning the patient and the ability to good images and recommendations. Staff want to see lifting equipment, other equipment that's suitable, and having extra staff to assist as well. So in summary, I guess the issues we're faced with, some of these patients have, not all, but some have delayed access to care because of the logistical issues in getting them to hospital. They have delayed time to disposition once they're in ED, require more resources, and we use CTs more. And there's a need for specialised equipment and accommodation, plus staff training when the patient's in the emergency department. So, thank you.
Thank you very much, Stuart.
So, thanks.